Hi guys, welcome to this recall of Obs and Gynae questions. And those who wrote the NEET PG exam today, I am sure you were very satisfied with the questions because we predicted most of the topics. What was more interesting that we could predict a few questions of these predicted topics, especially in the revision which I took for you guys 2 days back. And that was a quick fire revision on obstetrics and breech came. We had PPH and we discussed about CS cervix just 2 days before that. And CS cervix, what is the most common stage? All these questions also came. So yes, it's a very exciting time for me to do the recall, and let's quickly see how many of these questions you got right. Come guys, let's see question number one. A 28-year-old woman develops atonic PPH immediately following a normal vaginal delivery. She is hemodynamically stable. After initial steps and medical management have failed, then which is the next possible step to be done in the labor room? Yes, so once your go-to drug caroprost has also failed, then we must start doing the interventions, surgical interventions, and the first thing you can do in the labor room is the Bakri balloon. Yes, the tampon which we can give, we can put a balloon into the uterus, fill it up with normal saline, 500 ml, and that is going to compress the bleeding blood vessels. I'm sure you got that correct. Okay, B-lynch suture is done in the OT. You have to cut the abdomen, take the uterus out, and then do the B-lynch suturing. Of course, then you'll do the uterine artery ligation, the ovarian artery ligation, and then the internal iliac artery ligation. And if nothing works, hysterectomy. Right. So another short topic which we always keep doing on discussions is CA cervix. A 45-year-old woman is diagnosed with cervical cancer. Imaging reveals hydronephrosis due to tumor extension causing ureteral obstruction, but there is no evidence of distant metastasis. According to the FIGO staging system, what is the correct stage of a cancer? Yes, we know that the most common cancer, gynecological cancer of women in India is CA cervix. It is indeed the most common cause of postmenopausal bleeding. I've shown you in the recent revision that the Indian data, the recent Indian data also I showed you just to reinforce that it is the most common cause of postmenopausal bleeding. Now, women in India will keep having these symptoms, dirty vaginal discharge and foul smelling discharge, postcoital bleeding. They'll keep ignoring everything until unless one day the growth extends and hits the pelvic side walls. When it hits the pelvic side walls, it is a very painful condition, and this one will come to you more with the pain, and by then it is stage 3B. I know you got that correct. So this is the staging. This is how we've discussed this in the classes, and I've given you a color coding of the classes. And can you see this blue code? Blue code 2B is parametrial involvement, which is short of the pelvic wall, and this blue code on the right side, you see the blue growth which I've seen from the cervix. Then the green is the extension to the vagina, and the blue is extension all the way from the parametrium to the pelvic side wall. So when it is touching the pelvic side wall, it is 3B, and I've told you it is the most common stage, and it also compresses the ureter to cause a hydronephrosis. So yes, I'm sure you got this correct just as well. A 38-year-old woman who is gravid to para 1 with previous cesarean section is given a trial of vaginal delivery and is now in active labor with the vertex presentation, and station is at -1 and cervix is 8 centimeter dilated. Delivery is about to happen. She suddenly develops continuous suprapubic pain between contractions, maternal tachycardia, and fetal bradycardia. So suprapubic pain is sign of imminent rupture or a rupture, and then she's having a fetal bradycardia. First sign of rupture is maternal tachycardia. All of those things she's having. So this is a case of rupture uterus or just about to rupture uterus. What are you going to do? You're not going to wait. 8 centimeter means another 2 centimeters to go, which technically means another 2 hours to go. Please do not do anything else but a cesarean section. So yes, the answer is emergency cesarean section. Now there was a picture of a doctor doing a delivery with one hand on the abdomen and the umbilical cord in the hand, and she was rolling the umbilical cord on a, I think, on an instrument, and that looked like a control cord traction. So control cord traction, also known as the Brandt Andrews technique, which is the best method of removing the placenta after delivery. So I don't know the exact question, but I'm sure you got it. Now, a woman in labor develops cord prolapse. What is the immediate management? I think the dilatation given was 5 centimeters. So she's 5 centimeters cervical dilated and she's having a cord prolapse. What are you going to do? Yes, you're going to do immediately a cesarean section. That is the best answer. But what is the immediate thing to be done in the labor room? That was the question, I think. Cord prolapse, do a cesarean, end of discussion. But the questions were more specific. So the choices given was do a cesarean section, which is actually correct, but there was elevate the buttocks, which you should do. You should elevate the lower part of the body of the lady and give a Trendelenburg position, that is head low position to the lady, so that the presenting part, mostly the head, which should not be pressing over the prolapsed cord. So you should try to elevate the presenting part. So what we generally do, we can put the woman in a head low position or a Trendelenburg, which is elevate the buttock, and try to push the presenting part up. The presenting part we try to push up with our hands. We push the head up. Do not touch the cord. The cord has pulsations. It seems the question was giving. Do not touch the cord. The touching the cord is going to cause a vasospasm. So many times I think you people keep giving me an answer that when there's a cord prolapse, hold the cord and push it back inside. No, man. If you do that, you're going to cause a vasospasm and you're going to cause worse prognosis for the baby. He's going to be asphyxiated or maybe dead by the time he's born. So please understand, do not touch the cord. Try to elevate the presenting part by a head low and fill up the bladder with saline so that the full bladder will push the presenting part even more up. So what is the best first thing to do? What is the thing to do in the labor room? Elevate the presenting part by giving a head low position. So here I think elevate the buttocks is the best answer. Next, we'll generally fill up the bladder with saline and then we take her for a cesarean section. So what is to be done immediately in the labor room? Elevate the buttocks. Okay, this choice was there. I've asked at least 4 5 students who have given the exam, so I'm very sure that this is what you have to do. Now I'm telling you, these are the green top guidelines from the Royal College of Obstetrics and Gynecologists, and thanks to them we have a very easy way to justify what we are teaching you, that there is no data which says that replacement of the cord should be done, and to prevent vasospasm we should not be holding the umbilical cord, and to prevent the cord compression it is recommended that the presenting part be elevated either manually or by filling the bladder. So you can push the presenting part or you can do a slight buttock elevation and a head low by Trendelenburg position. Right, guys, have a look at these guidelines. You can pause it and zoom it and have a look whenever you have time, if in case you're revising this for your next exam and not just doing the recall today. Okay, what is the loading dose of magnesium sulfate in eclampsia? One day back, we have done the quick fire revision of obstetrics topic, and I discussed exactly this dose. So all of you know that the only regime which is important is the Pritchard regime, and please, all other regimes are outdated and ancient. Please, when I was in my MBBS, wow, how many years back was that? So then I was told 1993, 94, when I was doing my final year, it was told that read only Pritchard's regime. Other regimes are all outdated now. So now remember, magnesium sulfate is the drug of choice by Pritchard regime, and 14 grams is the loading dose and not milligrams. And 14 grams, how do you give? 10 grams is IM and 4 grams is IV. And of course, the method of giving also I told you in the recent recall that you should dilute uh, uh, the 4 grams IV injection which you're giving, and the IM injection you have to split it into two parts, 5 in one buttock, 5 grams in another buttock, and you should add 1 ml of xalocaine to prevent the pain which it causes, because 5 grams comes in 10 ml of fluid. So that 10 ml goes in one buttock, other 10 ml goes to the other bum, and it's going to be very painful. Add 1 ml of linocaine. So those were interns, and those are going to become gynae PGs. Please remember that part. Guys, let's move on. Mother had decreased fetal movements for 1 day and an NST was done. This showed one movement and an acceleration, but there was no deceleration. What is the next step? Now, this question, I'm sure the language was much more descriptive. Basically, they're trying to say that an NST was done and the NST is not showing a good reaction. What is a good reactive NST? Two movements showing two acceleration of more than 15 beats lasting for 15 seconds. So there's only one movement and one acceleration. This seems to be insufficient NST. So what we are going to do, you're going to wait another 20 minutes. That is, do the NST for 40 minutes. All right. But yes, if this question was asked for a woman who is a diabetic, so please don't say that it's a diabetic woman and NST is non-reactive, give her a meal. Diabetes women will already have high sugars. So don't give her a meal, do a biophysical profile instead. So diabetes was not there in the choice. So the answer here is continue NST for 40 minutes. Next question, shoulder dystocia management, guys, as always. Hot shot question for MCI and for PG entrance exam, and I'm sure you got this correct. What is the correct sequence of management? So always remember Mac Roberts first and then suprapubic pressure, and exactly that's what have come in the exam. Mac Roberts is flexion of the hip joint more than 90 degrees. suprapubic pressure, Rubin's maneuver, and then you can do the Wood's corkscrew maneuver, which was not asked here. You can otherwise do the Gaskin maneuver, which is also known as the all fours maneuver. And then the last thing, if nothing works, you can do the Javanese restitution. All right, that's the chain of events. I've given that, and again I've given that here also. Let's move on. A lady with irregular cycles has amenorrhea for 2 months and pregnancy test is positive. She has irregular cycles. She doesn't know when was the LMP, and it is not going to correlate for her pregnancy duration. So if the pregnancy test is positive and she is not sure of her dates, first trimester ultrasounds are better, the predictive of the exact gestational age. In the first trimester, the parameter which is even more better than the other, it is the crown rump length. You got that in your sleep. I'm very sure this is that easiest question which came for you guys. During a standard mediolateral episiotomy repair, which is the correct sequence in which the layers should be sutured. All you interns got it correct. All you hard-working interns who went to the labor rooms, who did episiotomies and worked in the wards, those guys have got this paper correct. I'm very sure. And first is always the vaginal mucosa with a continuous suture. Then it is interrupted suture for the muscle, and then interrupted sutures for the skin. So yes, mucosa, muscle, and skin. Choice B is the answer. You got it correct. But what material are you using? Non-absorbable or absorbable? What are you using? So absorbable material is used. Mostly nowadays we use synthetic absorbable. In my days when I was in my PG, we used to use catgut, natural absorbable. Nowadays we're using mostly vital synthetic absorbable sutures, so that she doesn't have to come for a suture removal, isn't it? Move on. During a breech vaginal delivery, yes, I told you guys, read breech. I even mentioned that the big hospital guys will keep telling you that if there's a primary breach or whenever there's a breach, do a cesarean section, and they will ask you questions on breech vaginal delivery in the exam, and exactly that's what has happened this time. And when there's a breech vaginal delivery, after the delivery of buttocks and the trunk, the fetal scapula is found to be winging, a winged scapula. So winging of scapula means the scapula should be flat on the back of a human and of the baby also here. So the scapula is a little bit risen on the back, winging of scapula, just like in birds if you see. So when the scapula is a little winged, it's a little elevated, that means the arms are extended. And what do you do for extended arms? Yes, day before yesterday, I'm giving you the link here in the bio. Just remember, I told you exactly that when a breech is delivering, flexed legs and flexed arms is good. Extended legs, you'll have to do maneuvers, and extended arms, you'll have to do maneuvers. And for extended arms, you have to do Loveset maneuver, and for the extended legs, you have to do the Pinard's maneuver. So answer here is Loveset maneuver, guys. I think this picture was also given. They showed that the doctor is turning the baby and trying to take the arm out. So this is what you see this in extended arms. You'll also see in a nuchal arm, but we'll discuss that some other time if there's a nuchal arm. So winging of the scapula, I got this from the NHS guidelines so that you guys know that when I'm telling winging of scapula was the information given, what does it mean? So when the winging of scapula is seen, the baby may have become startled with arms extended, or if there is a nuchal arm. All right, guys, let's move on. A 35-year-old lady with amenorrhea for 1 year, AMH levels is 0.5, FSH and LH were high, that is more than 50 international units each. So what is the diagnosis? The diagnosis with the high FSH and high LH and low AMH for a 35-year-old woman, these are not the values which you see. 0.05 is the AMH level given here. Normally the AMH is 2 to 6 nanograms per ml. So this is very, very low. 0.05. So that means this woman's ovarian reserve is gone. She's not making any eggs. That's why she's not making any estrogen progesterone. So there's no feedback to high. There's no feedback to the FSH and LH. That's why the LH and FSH is high. That's a case of premature ovarian insufficiency. So let's move on, guys. Now this question, there were a lot of similar questions. I think there's a overlap in the recall which came to me, but never mind. Let's see. A 65-year-old post-menopausal woman presents with bleeding per vaginum. She undergoes a total hysterectomy. The specimen of the uterus shows the following. Which of the following is the most likely diagnosis? So there's a cut section of the uterus, and inside the cavity, can you see the cavity here? There is some fleshy lining of the endometrium, thick fleshy lining of the endometrium. So woman who is menopausal, thick fleshy lining of the endometrium cannot be anything else but endometrial cancer. Now this is a picture which came from a student, a recall. Now if the uterine muscle was big, and it was uniformly enlarged, then we think in adenomyosis terms. So here it looks like a case of endometrial cancer. Fibroids generally don't present at this time. Fibroids will have a more irregular growth. And the only thing which I was thinking, maybe they asked you adenomyosis, but the picture should have been something like this. Adenomyosis, there'll be uniform enlargement of uterus and there'll be blood spots. This is a preserved specimen in formalin in my hospital, but generally if they showed you cut section of the uterus with these blood spots, then that is adenomyosis. But the picture shown to you here was in the cavity there is a fleshy lining. It goes in favor of endometrial cancer. Now, again, another question of a 65-year-old woman with high CA125 levels and abdominal mass. She undergoes a laparotomy, which reveals a large tumor. And this large tumor with high CA125 in a older woman beyond 50, classical presentation of epithelial ovarian tumors. And that epithelial ovarian tumor is mostly serous cystadenocarcinoma. So I told you guys that the most common ovarian tumor is epithelial, and in epithelial, which is the most common, serous cystadenoma. So what is the overall most common ovarian tumor? Serous cystadenoma. And exactly that's what came in this exam. All right, guys. A 38-year-old multiparous woman presents with a mass protruding from the vagina associated with sensation of pelvic heaviness and difficulty in urination. She had two previous home deliveries conducted by an untrained birth attendant. What is the most common cause of prolapse? Abnormal conduct of labor. Remember these lines of the classes? Okay, so this is a case of prolapse. So what ligament is weakened primarily responsible for this condition? So I told you the best support of the uterus is the pelvic floor, and ligaments are also very good supports. And in ligaments, which is the best ligament, the McEnroe ligaments or the transverse cervical, or also called the cardinal ligament. And it seems McEnroe was the name given here. So answer is McEnroe's ligament. Broad ligament is not a support of the uterus. Sacrospinous ligament is not that great a support. The best, it is a round ligament, McEnroe ligament, and the uterosacral ligament. They are the best three ligaments. Also the pubocervical ligament, but the best is the McEnroe. A 60-year-old postmenopausal woman with blood-stained vaginal discharge. On examination, her blood pressure is 170 by 110. She has no history of trauma or hormone therapy. What is the most appropriate next step in her management? High BP, irregular bleeding. So I've told you always, never think in terms of doing a management till you know the complete diagnosis. And for the diagnosis, we'll do the examination of the lady first. If the vulva vagina cervix is fine, then we go ahead and do a endometrial biopsy, endometrial evaluation for malignancy. We don't give hormones without knowing the diagnosis. And cardiology opinion can be given. You can also manage blood pressure. Cardiologist will help you, but you can also manage the blood pressure. So that's not the most important thing here. And reassure her it is not normal due to low estrogens at 60 years. No, it is not normal. Any postmenopausal bleeding has to be investigated. A 46-year-old woman presents with abnormal uterine bleeding. That's why I was saying there's a lot of overlap in the questions. I hope I'm getting them correct. A transvaginal sonography reveals an endometrial thickness of 14 millimeters. Again, the answer is to find out what is wrong before you give the management, and that is to find with the endometrial biopsy. Don't do a hysterectomy, please. Hysterectomy is never the first answer. Investigation is the first answer. Now, guys, what is the drug of choice for prevention of venous thromboembolism after a cesarean section? So, when women are high risk, like obese women, slightly older women, after a prolonged cesarean section, they could be, a deep venous thrombosis if the patient is bedridden for a couple of days. So, remember, pelvic surgeries are the most common cause of deep venous thrombosis. So, we can prevent it by heparins. Now, it can be unfractionated heparin or it can be low molecular weight heparin, but low molecular weight heparin is a much better answer because the onset of the action is much faster, more predictable action, much lesser side effects like osteopenia, thrombocytopenia, all of these are much lesser. So answer straightforward, low molecular weight heparin. I'm sure you got that. A 26-year-old woman presents with amenorrhea, breast enlargement, linea nigra, and bluish discoloration of the vaginal mucosa, Chadwick sign. According to the classification of signs of pregnancy, this falls under which category? New question, the same topic, but with a different method of asking. So these changes, which we keep thinking, Hagar sign, Chadwick sign, and then there is the Osiander sign of pulsatility in the lateral vaginal fornixes. All these signs fall under the presumptive diagnosis of pregnancy. All right, not definitive answer. not definitive diagnosis. These come under the presumptive diagnosis of pregnancy. All right, guys. So I hope you got them, and it's not diagnostic. So, guys, those are the questions which were given to me in a recall by my students. I hope I've not missed many of them. Just in case if I have, or if the choices were not, if they were very much away from the ones which I recalled, so you can always discuss with me in the chat on the YouTube itself. I'll try to answer them as soon as possible. And happy Friendships Day, guys. Time to unwind, go out with your friends and enjoy. Your INICT exam is still a few months away. I'm sure all of you should settle this time itself. So go ahead and celebrate. Go visit an exciting place like I visited Taj day before yesterday with my family, and it is so beautiful in the rain. So exciting and just as beautiful as always. Best luck with the results once again, guys. Bye bye.